And I'm an acting instructor of emergency medicine at the University of Washington School of Medicine, and I work with the Center for Health and the Global Environment, as Lori mentioned. Just a brief roadmap of what we'll talk about specifically around the ICD10 stuff today. First, we're going to go through some clinical cases, which kind of help to illustrate the problem that I'm trying to get at. We're going to define the problem, and we're going to go over the solution that my group kind of came up with to address this problem. We're going to briefly go over the specific codes that can be used to document climate exposure, and then also talk a little bit about the anticipated challenges of the approach that we're proposing here to better capture climate-related health outcomes. We'll talk briefly about next steps, and hopefully we'll have some time for questions, and then we can talk about the ClimateRx product. So the first case I'm going to go into is about a 13-year-old boy who presents, this is a case that I had, to the emergency department with family in Tucson, Arizona, due to confusion. The family states that they were out on a hike in the desert and it was hot and they admit to not bringing enough water. They also noticed that their son wasn't really acting normally after approximately 2 hours into the hike and seemed to be slurring his speech and was also very slow to respond to questions. The child's otherwise healthy and doesn't have any other significant past medical history. For the workup, we found the patient to be hypotensive, tachycardic, and febrile, and saturating well. The patient was disoriented, slow to respond, tachycardic, and with skin with decreased skin turgor. I'm glad that most everyone here is medical professional, so knows what I mean when I say that. I've run up to against a couple of audience who had no idea what I was talking about. In any case, we proceeded with appropriate management of the patient, treating for suspected heat stroke, which is something that we saw a lot in southern Arizona, as you might imagine. And then for the conclusion of the case, the patient was cooled using non-invasive techniques, evaporative cooling measures were used. Eventually, the patient was intubated due to airway protection because he was seizing, and we weren't able to lower his temperature fast enough and wasn't protecting his airway. We applied just Arctic Sun, and we eventually admitted the patient for heat stroke to the PICU. And for this particular case, the ICD-10 codes applied to the case, and this is a case that I had during my residency, were altered mental status, unspecified, acute kidney injury because he had an AKI, and acute respiratory failure because he wasn't protecting his airway and we had to intubate him. This just another case we'll go over. This is a 6-year-old female with history of mild intermittent asthma presenting due to difficulty breathing. This is a case I had in Seattle when I moved here over the summer, and the family states that they had to pick up their child from school because she was having a hard time breathing. She'd been using her albuterol inhaler more frequently due to all the smoke from the wildfires, and she had no high-risk features for her asthma, including no history of intubation or prior hospitalizations due to her asthma. For the workup, the child was a little bit tachypnic and a little bit tachycardic, but otherwise doing okay, awake and alert, appropriate mental status, and didn't have any increased work of breathing, but did have expiratory wheezing in all of her lung fields. Because we're all medical professionals, I won't go into the management, but of course we treated the patient for an asthma exacerbation, and ultimately this patient was coded as unspecified asthma with acute exacerbation. So what's the problem and why am I presenting these cases to you here today? For our purposes and for those attuned to how climate is impacting health, I think that the problem is that we're not capturing the context driven by climate change. And in both cases, the health outcome is not linked to the climate exposure. For the first one being heat and a heat wave, which was occurring during that time, and for the second, the wildfires that were so dramatically impacting the air quality in Seattle. So, and the cases I just reviewed, they do a good job of illustrating the problem as it applies to our clinical sphere. But we know that we know that there's a much larger problem at play here. And we all know the message conveyed by this slide, that the message that every major credible health organization and governing body around the world, including the WHO and the Lancet, have espoused, which is that climate change is the biggest global health threat of the 21st century. Mm-hmm. But more specifically, we know that climate change, together with other natural human-made health stressors, influences human health and disease in numerous different ways. We know that the existing health threats like air pollution will intensify and new threats will emerge. And we also know that the impacts of climate change on health will not be felt equally, and that certain parts of the world will see the effects sooner, and certain populations will, of course, be more vulnerable. That's all really to say that we already know a lot about climate change and how it impacts health. But really, what is the true magnitude of the impact of climate change on health? And the answer, I think, to this question really matters. It matters for us, it matters for policymakers, it matters for educators and emergency managers, and it matters locally and on the global scale. But consider this: between 2030 and 2050, this is what you would get if you were to Google what is the impact of climate change on health. And this is what you get from the WHO's website. The first page that comes up, that between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from malnutrition, malaria, diarrhea, and heat stress. I guess like the overarching question is, does that really sound right to you? And I think the majority of the people that I encounter, they balk at this number because they know that the impact of climate change on health is so much worse than this. But what is the actual impact on health? And let's consider the other end of the spectrum, because just last year, Victor Zhao of the National Academy of Medicine is quoted as saying that already some 20 million people are dying every year globally because of key factors linked to climate change. And so, these are pretty drastically different estimations of the burden of disease related to climate change. And I think that that's a problem for our cause in general. Mm-hmm. And so, but let's briefly take a step back. This is kind of the overarching cause and effect relationship that we use to think about climate change and how it impacts health. Obviously, we know that it's quite a bit more complicated than this, with social determinants of health and other key factors playing a role. But this is kind of the 50,000-foot view, with climate drivers resulting in environmental conditions that spawn environmental hazards that lead to health effects. I think we're already pretty good at capturing the health effects, but the problem that we're trying to address here is, how do we know that they're related to climate change? This is what we're missing. And we as healthcare professionals are failing to capture this exposure pathway. So again, taking a step back, what is done now? How do we currently capture the magnitude of the impact of climate change on health? And this comes to detection and attribution studies. Detection and attribution studies help to establish the causal relationship between greenhouse gas emissions, climate-driven hazards, and observed health outcomes. The problem is that the results of these studies offer probabilistic estimates demonstrating the likelihood of a climate exposure resulting in a particular health outcome, but there are a wide range of inputs, including the fact that climate-influenced extreme events rarely are rarely the sole cause of a given health outcome, and this results in a considerable degree of uncertainty, and therefore, when it comes to these studies and the absolute magnitude of the impact, a large confidence interval when it comes to that number. And ultimately, DNA or detection and attribution studies rely on retrospective analysis of environmental hazards necessarily and associated health impacts, and are often separated from the event in both space and time. And therefore, epidemiologists rely on information like ICD-10 codes to paint a picture of what the health impacts of climate change, of climate-related events, or like a hurricane or a heat wave are like, and are therefore limited by that separation in space and time. So, to getting to what we did and what we're proposing is really the question of how we can improve here. So, current efforts can be improved. What we think is that current efforts can be improved by adding the climate-specific nuance and context available to clinicians at the point of care, and equipping clinicians and eventually decision makers with clinically enhanced climate data can inform responses and motivate, I think, an expanded ambition to address climate threats. So, before we jump into what we specifically did, just a brief review, and don't fall asleep on me here. I know that this isn't anyone's favorite topic, but the ICD-10 ultimately is a really powerful lever for change. As a brief review, ICD-10 codes are used to document the health status of the patient over the course of their interaction with the healthcare system, and of course also subsequently used for medical billing purposes. ICD-10 codes can also be used to track prevalence and incidence of human diseases and health outcomes, and they're also used by regional and state public health systems to track incidence and outcomes of disease in any given population. But specifically, I want to zero in on external cause codes. And these are secondary codes that capture specific details about an injury or health event. Put differently, they capture the whole story of a patient encounter. And what we did, myself and a group of researchers that's kind of in the diaspora, was examine the over 72,000 ICD-10 codes in the CMS archives and cross-reference this database with 29 keywords for climate impacts that were determined using consensus literature, including from the CDC, the WHO, and the bibliography of the fourth National Climate Assessment. Our inclusion criteria included any code that provided a relevant context or clinical outcome related to a climatic event. Our exclusion criteria included any code that referenced irrelevant clinical context, for example, heat exposure on board an unspecified watercraft, any code that explicitly excluded an environmental exposure, including things like hyperthermia not associated with low environmental temperature, or any code with an ambiguous clinical application, for example, other effects of heat and light. And here's what we found. These are the 46 unique ICD-10 codes that we identified, and they're here categorized by the climate-related keyword that we searched for. And these are then expanded to 100 total codes when accounting for all of the qualifiers, including that we know of with ICD-10, including initial encounter, sequelae, and subsequent encounter. Perhaps even more significantly than the codes we did find were the codes we didn't. Each of these climate-related keywords yielded no ICD-10 codes in the over 72,000 ICD-10 code database provided by CMS. And these all represent important exposure pathways related to climate change that are not adequately captured in the current iteration of the ICD-10 system. And what we hope is that the widespread application of a more precise climate-sensitive coding could help to inform more effective and data-driven climate adaptation strategies. Again, going back to that model, if we go back to that model, we see that the basic visual model of the cause and effect relationship between climate change and health, what we hope is that by advocating for the use of ICD-10 codes to capture climate-sensitive health outcomes, we can better capture the hazard and environmental condition that leads to the specified health effect. Now, this is essentially also conveying the limitations of the current ICD-10 system, because prior studies actually have demonstrated that the current application of ICD-10 coding for surveillance of health harm related to extreme weather events is inadequate. In the case of extreme heat, for example, research has indicated that mortality estimates may represent a 50-fold underestimation of the true burden of disease related to excessive natural heat. And I think our review highlights an important limitation of the ICD-10 system. We know that surveillance of health effects of climate change relies on data collected from clinical care settings, and that the quality of this surveillance correlates with the ability of the EMR data to accurately reflect the full scope and scale of potential harms. We also know that human physiology and pathophysiology and their associated ICD-10 codes don't really need to be updated. What needs to be updated are pathways of exposure to harm related to climate change. So, a few challenges that we anticipate and have already encountered in some of this work. First, we'll address attribution in the clinical setting, the uptake of codes like this, like the external cause codes, and the cost conundrum. So let's first address attribution in the clinical setting. So surveillance of public health threats posed by climate change is currently performed by groups like the National Syndromic Surveillance Program at the CDC. And this work really is critical for supporting patient surge and other disaster planning related to environmental stressors. But what we're saying is that we think that their data sets are incomplete, and that clinicians are uniquely positioned to interpret the context of health outcomes. I think we also think as a group, and talking to many clinicians, that it's within our scope of practice as clinicians to accurately apply the codes presented here. But we also acknowledge that this may not be a task that all clinicians are comfortable with, and that leads us to what's needed to support this attribution in the clinical setting. And that includes education. We need a concerted effort to educate clinicians and the health professional workforce at large, both about climate change and health in general, but also the specific application of these codes. We need an interdisciplinary effort where we all know that it's not just the clinicians themselves applying these codes. There are coders and care management and social workers who also apply codes. And we also need help from clinical support, decision support systems that are applied in electronic health records like Epic that can prompt you to say, hey, it's 108 degrees out. Could this heat stroke that you're coding have anything to do with the heat wave that is actively going on in the area? Next, uptake. And what do I mean by uptake? And what I mean is provider utilization of ICD-10 codes designed to capture climate-sensitive health outcomes. And the important clinical correlate here that many of you are probably familiar with are Z codes, which face similar challenges for uptake. Z codes are currently tied to reimbursement, and the same goes for external cause codes. There's generally a lack of awareness amongst clinicians about Z codes and their importance for documenting the social determinants of health. And there's also a great deal of heterogeneity of health systems and poor interoperability between different EHR systems, which makes the application and use of these codes even more challenging. So finally, cost is one of the challenges that we have to kind of address. And some may say that more coding means you're just really trying to upbill patients' charts. But the reality with external cause codes, for better or worse, is that external cause codes are not currently tied to reimbursement. And we also recognize the disproportionate burden of climate-sensitive health impacts on economically vulnerable groups. So we by no means would be advocating for upbilling patient charts. What we're advocating for is the use of E-codes and expansion of E-codes designed to more accurately reflect the circumstances that surround an injury or illness. The next steps that our group is hoping to pursue is kind of first a proof of concept study. If we implement an educational intervention around these codes, can we increase the uptake and use of these codes? Second, how can we advocate for the inclusion of additional codes that better capture all of those exposure pathways related to the climate that are not currently addressed in the current iteration of the ICD10. And some of this has been taken up by advocacy groups, including Climate Health Now. And what they're trying to do is to introduce climate health related billing resolution to the California Medical Association. And we're helping them with that. With that, I'll open it up to some questions. And then if we have some time after that, which I imagine we will, we can talk a little bit about Climate RX. And I'll stop my share so we can chat a little bit.
Great. So you have two people here super involved. Cynthia works a whole lot with Climate Health Now, and Don Gady works a whole lot with the California Medical Societies.
Great.
Just unmute yourselves.
I'm just reading some of the comments in the. Lori.
Yeah, I just want to start out by saying I think this is great that if we don't think about these exposures and have any way to code them, it's like it didn't happen. And so approaching this is really great. And I think we need to make it so it's easy both to jog people's consciousness that this could be going on, because we're so focused on what we see right there. Hence my comment in the chat that it would be great to just automatically have like a weather alert show up on the vital signs page that would be recorded without the physician having to do anything, but could then inform the diagnosis, could inform the coding all the way along, and just make people much more aware, but without asking people to do too much more work themselves, because so often the burden gets put on the provider. So yeah, very, very interesting work. Thank you.
Yeah, thank you. And yeah, you're absolutely spot on. Yeah, that's one of the problems that we run into, just physician burnout with different notifications that they get in their EMR. I'm not sure that they really need more, but that is one of the solutions that has been proposed, and we're working with a couple of health informatics folks who have worked with EMRs like Epic to help introduce prompts that can help with something like that. So yeah, it's a potentially really powerful way of helping to introduce something like this, and has been used for Z codes in certain parts of the country. And I just gotta briefly say hi to Deirdre. Yes, I do know Tim. I haven't talked with him in a while, but I have the great fortune of getting to mountain bike with him several times in Vermont. So yeah, that's crazy. Small world.
Yeah, thanks so much, Stefan. Don Gady here. And you mentioned the attribution aspect, and we all know that extreme weather events, the attribution, they always talk about the climate change greatly increases the probability of extreme weather events, but you cannot absolutely say this event was caused by climate change. So what's your thinking on that?
Mm-hmm.
Yeah, and none of the codes that we're using here say are asking a physician to say, this injury or this illness is because of climate change, right? What we're saying is not to make that leap, because that's not a reasonable expectation of a clinician. Mm-hmm. What we're asking is, if there is a heat wave or there is a hurricane going on, I think it is within the clinician's scope of practice to be able to say, yeah, I'm pretty sure that this person going without their insulin for multiple days because they were displaced from their home and didn't have access to it because of a hurricane might have had something to do with that hurricane, right? So it's not making that huge leap. It's making the smaller leap of saying this direct climate exposure may have led to this illness or injury.
Okay, got it. So you could code for the extreme weather event, but not saying that's due to climate change.
Right. So you can say, the external cause codes would allow you to, code for a heat wave, which again provides that clinical context of why that patient ended up in the emergency department or in the hospital in the first place.
Got it. Great, thanks.
Dr. Dooley?
Yeah, I had one comment, but now I have two on that. I have absolutely 100% confidence given our heat dome in Seattle last year in saying that the people who came into the hospital with the temperatures of 106 and the acute kidney injury that I saw, that it was a direct result of climate change. Am I going to use the word cause? No, but I try and be very simple when I'm talking to elected officials and politicians in the Seattle area. I don't use the word cause, but I say it was a direct effect. But my real question was, Stefan, you're just across the lake from me. I'm at Overlake across Lake Washington. But, I just discovered the Z code 3 weeks ago when talking to a pulmonologist trying to code all these asthma exacerbations they were seeing in pulmonary clinic. Are people actually using them? Because I just discovered them.
Yeah, no, Z codes have been around for a while now, and you're not alone. The vast majority of clinicians across the country are not familiar with them. Most clinicians, at least at this point, are familiar and, at least to some degree, comfortable talking about the social determinants of health, but not necessarily the codes that we use to help capture those social determinants of health. And so, yeah, we see that as very much a barrier to this as, a larger, solution to this problem. I don't think that we expect that this is going to solve the whole problem of identifying the magnitude of climate change on health. But we hope that, especially with the growing number of clinicians who, seem to care and are interested in how climate change is impacting their health, we hope that this can be kind of a piece of the puzzle. Cheryl?
Yeah, hi, good evening. Sorry, I'm a little late. In North Carolina, the Medicaid waiver program, they got a waiver for children looking at social determinants of health and finding a way to get extra dollars by using that. I don't know if you've looked at that aspect, because we're in Florida and coding has been a big thing I've been trying to, and the medical consortium is trying to get implemented in some way that could find a way to make dollars. And North Carolina's waiver with the Medicaid waiver has allowed them to do the waiver and do the social determinants. And any thought of including heat as a waiver through the Medicaid, especially not just heat, but climate change and asthma, and that might be a way of getting funded. So that's my first question. My second thought is the research you're looking at of implementing some of these Z code concept. Have you looked at other sites? Because Florida would be interested in partnering and taking something like this through IRB that we could try it. Our heat causes 34 excess deaths when we do the analysis, but it's not in heat wave, it's just a chronic exposure.
Yeah.
So we know it's a year-round data collection that we have to do in Florida. And so something that's trial that we could do some research on using codes would be great.
Yeah. And I'll address your second point first, is that we have not identified a great or a partner to be able to actually try and do that proof of concept study yet. We're kind of just in the midst of trying to get some of this work published now, and then that's kind of our next step. So I think we'd be very interested in kind of exploring what that could look like, in Florida or really anywhere. And to your other point, again, the cost and is it's a big problem. And I say it's a problem is because you don't want to be up billing someone's chart, but ultimately it's really, really challenging as we've seen with Z codes that document the social determinants of health. It's really hard to improve uptake without reimbursement being tied to it. And the places where, and there are certain places and health systems where they've been able to integrate that and make, it just makes good sense, right? We all know that the social determinants of health are, really, really important for our ultimate health outcomes for our patients. Why shouldn't they be tied to reimbursement? It's really just more of a question of where does the burden of that cost end up. And most places where this has seemingly been successful, for Z codes at least, that extra cost of the reimbursement around those codes is not passed on to the patient. So I think that's kind of a model for what it could look like in the future, but I think it's up in the air right now.
Thanks, but think about the waiver concept that may at least it'll get to the most vulnerable populations earlier than trying to figure out the other areas using a Medicaid waiver.
Yeah, no, it's a good point. Yeah, I'll have to look into that a little bit more.
Can you educate those of us who have merely just lived with these codes as to who's actually who's doing the updating of them, I guess?
Yeah, so it's a team at the CDC that on a semi-annual basis, they take a look at the codes that currently exist and propose additional codes. That goes, some of this is also a mystery to me, but that's their proposed additional codes that they want to add to the ICD10 system. Goes to a committee at somewhere within CMS and are approved or not, and then generally that's then sent on to the international governing body through the WHO that approves these codes as well.
Okay, and so I'm wondering if it goes through CMS eventually, are you aware of all the work that CMS has been doing recently on like looking at climate change and looking at how they can incentivize hospitals to look at sustainability and all this kind of stuff, that it just seems like this would be right up their alley to start looking at this too?
Yeah. I am familiar with some of the work they're doing. I as part of my fellowship at the University of Colorado, I worked with the Office of Climate Change and Health Equity in the Department of Health and Human Services, and so I was working and on a daily basis talking with some of the folks who are looking at some of the levers for how CMS can incentivize some of this. And we have not at this point reached out to suggest that this is something that they pursue. I think we would hope to kind of have some evidence to back us up that this could be an effective solution. And so we want to, I think, go to that proof of concept study next.
It would seem like with 72,000 codes and with codes that are, you could have a party just laughing at the crazy codes, when you try to find them, dismemberment of an upper extremity caused by a medium-sized motorboat,
Yeah.
you're crazy. You only need like 50 more codes or something, which is nothing to really have a lot of climate related codes in there. It would seem like that'd be a pretty easy ask.
Yeah. It's something that's on our radar, and we're hoping to kind of pursue that at some point, but we haven't gotten to it yet. And if there aren't any other questions, since we have a few more minutes, Lori, since you mentioned wanting to hear a little bit more about the Climate RX product, I'll just share my screen again and we can jump to that. I'll just have one slide on this. Climate RX is a badge tool which I created and pitched to the NGO Eco America during my fellowship, and it's inspired by a similar product, which is called VoteER, which many of you may have encountered during your clinical work, which was a campaign started actually by an emergency physician at Harvard. And what he kind of recognized was that voting is very much a health issue, right? How we vote very much ends up impacting health outcomes. And yet, it was a topic of discussion that seemed almost taboo in the clinical arena. It's not something that most clinicians thought was appropriate in the clinical space, and it's not a conversation that clinicians were having either with their colleagues or with their patients. And so what he created was something very similar to this, was a badge buddy that was attached to clinicians' ID badges, and it had a prompt that helped their colleagues and patients say, hey, why are you wearing something that has something about voting and health? And then similarly a QR code which linked to resources and information around voting and health, but also specifically to allowed the patient or colleague to register to vote directly through the QR code. And so, I kind of, when I was initially starting my fellowship, kind of saw climate as a similar problem. It's something that, many, the primary barriers to climate change being discussed in the clinical space, one of them is that many clinicians don't see it as a clinically relevant topic still. Many also think that it's outside of, their job responsibility, or they don't think that they have time for it, which is, also very reasonable. Clinicians are already overtaxed and overworked. So, that bandwidth is definitely a problem. And then finally, the other primary barrier that most clinicians identify to actually engaging their patients around climate change and health is that they don't feel educated enough around it. And again, that's, not probably relevant to this group, but the larger health community, most clinicians don't feel that they are well educated enough to have a conversation with their patients around this issue. And so, this badge and this campaign is really designed to break down all of those barriers, because in terms of addressing the problem of it not being an appropriate or relevant issue in the clinical space, this combats that barrier by creating an actual community of practice. You actually see your colleagues wearing this badge, and you see that there are other people who care about this issue. You can come out into the light and say, hey, yeah, this is something that I care about and something I care about teaching my patients and my colleagues about. It also is non-interruptive, recognizing that clinicians are already too busy to realistically sit down and have a whole conversation around climate change and how it impacts their health with their patients. All this requires is that clinicians act as kind of a conduit to, if patients or colleagues are interested, all they have to do is scan that QR code, and they're linked to a lot of information about specifically how climate change is impacting their health, depending on different regions where they live, and also what they can do to help mitigate their impact on climate change, and what they can do to help protect their health. Yeah, so it's addressing all of those barriers, and of course, the final barrier being education. It's not requiring that you are an expert in climate and health, right? It's only requiring that you care about this problem and care about protecting your patient's health, because all you have to do is let your patient or colleague scan the QR code to be able to get involved and learn more. So that's kind of the brief overview of the campaign. It's live and just went live in October. So it's a relatively new campaign. You can, colleagues who scan the QR code can go to the website and have a badge delivered to them free. And any one of you can do the same. Just go to climaterx.com and you can sign yourself up and you'll have a badge delivered to you for free. And yeah, it's very new. We have a number of great partners, including Kaiser Permanente is distributing badges to their practitioners in the Pacific Northwest. The American Public Health Association distributed badges at their national conference just a couple of weeks ago in Boston. And yeah, it's starting to catch on.
Great work. Thank you.
Is there a website for ClimateRx?
Yeah.
Yeah, it's in the
Yeah,
chat.
so it's
Oh, I
climaterx.org.
see. Yeah.
I was curious, when you go to it, is there state-specific information or is just general 101
There's
climate
region-specific information
region
that
specific?
patients. So
Okay.
most climate-related exposures are, most relevant at least a regional basis, and that's why we're trying to provide that information.
What about
on a
language?
regional basis.
What about languages? I'm in South Florida, but I have Spanish and Creole. They don't use
Yeah.
it.
So currently we have it in English and Spanish.
Oh, okay. All right. That's something to look at. We're creating a similar program around heat, and our QR code takes us to our site, the Florida Clinicians, but then we'll have things in the 3 languages. And we're creating
great.
material in the 3 languages, but it's all pretty much around heat. That's all we were funded to do. So this is
That's
something
fantastic.
to look at and see. And we have a whole team that we're training to go do it clinic to clinic in the vulnerable areas that we've mapped out already. But this is something I look at to see perhaps at the end of the training, and they might be able to sign up and get a Climate RX badge too. That's all I have to say.
Yeah, absolutely.
Yeah.
Yeah. Well, I think, the more local, the better with some of these things. So yeah, that's great to hear that you're pursuing that with heat.
Yeah, but this is something good to add. Thank you.
Yeah. Well, if there aren't any other questions, thank you so much for inviting me to come and talk with you guys a little bit here tonight.
Thank you. This was great.
Yeah, thanks, Stefan.
Thank you.
Super, yeah, super interesting work.
Thanks so
Yeah,
much.
we'll invite you to Florida too, if that's possible. We do it by Zoom.
Yeah, please. Yeah.
All right. Okay,
I'll
thank
drop my email in the chat if you want to reach out.
Yes,
Yeah,
please do.
Stefan, yeah, sorry, Cheryl. Stefan, since you're so close to me, I might contact you, since you're just across the lake, about having more conversations with patients.
Yeah, please.
And maybe I'll take this opportunity to mention that I actually work with Climate Health now. I'm one of the co-founders, and we actually branched off with a new group called Voting for Climate and Health, where we're trying to use that voting message as a social determinant of health, which of course the AMA actually recognized formally this year, which I think is great. And to get that message that voting is a social determinant of health and mobilize all the climate concerned health professionals to combine those 2 things. So that's something that we're working on. We have an infographic that actually Robin Cooper actually had to sign off, but is hosted on their Climate Psychiatry Alliance page. I don't actually know how to get it to open up in this chat, but if anyone's interested, I can share that. And it's, again, trying to help health professionals understand that they have a role in this, and they can help. It doesn't really educate them about climate, but that they can talk to their patients about, hey, this heat wave happened, your kidneys are damaged, And it's important that you vote so we get the policies we need to start addressing this. And the non-interruptive, very simple, short message, but then turning it over to the patients to get that systemic action that we need.
That's really exciting.
And since we're all in different specialties here, yeah, it's worth noting, you know, people have looked for years at how to get more climate education into medical school, into residency.
Mhm.
Some people have felt like everywhere else, people teach to the test, and if we get it on the boards, you know, we'll get it more in medical school. And it took about 3 years worth of work, but finally got Cecilia Sorensen on the board of the USMLE. So we're hopeful that you know, she'll eventually be able to get some climate questions there. And of course, there's tons of residencies at medical schools that are working on this, and GCCHE keeps track of some of them, but it's actually only a small fraction because the deans have to sign on. And there's a lot of people doing this. I mean, among the pediatricians, I know 50 to 100 places that are doing it, but none of them are on the list because, you know, that's just a couple more people up the chain to get a dean to sign on to it. But one thing that pediatricians have done, and we like to challenge everybody else to give it a try, with our board, we have not gotten it on the board exams, but what we've gotten it in is in the maintenance of certification. So when you have to recertify every few years with your board, you know, of your specialty, we have a climate change and human health training that you can get CME for and get maintenance of certification credit for. And we just created a new one on it's a QI. You have to do QI, which is another total topic, but it's a QI on how to incorporate talking about climate change to your patients. And so that'll be available pretty soon for the pediatricians. And we actually found that the American Board of Pediatrics was pretty open to having modules that somebody else created. So, you know, you might find that with your own boards too.
You know, there's actually California has a forum, the California Preventive and Public Health Leadership Forum that meets maybe every 2 months. And they are currently looking at incorporating social determinants of health, including environmental determinants, into the curriculum of all the medical schools. And it's a nice collaboration between public health and the more traditional medical schools. Because it seems like a lot of the problem that we're in is that there's been this siloing of what public health people know and are concerned about, and the standard Western medical education that leaves it out. So I think the work you're doing, Lori, with getting this in CMEs, and I'd like to see it a requirement, like California has a requirement that you have to take a module, even practicing physicians, on pain because of one person who sued 20 years ago at the hospital I happen to work at. And it's just amazing to me that we don't have any required CME for the greatest public health threat of the 21st century. And yet so many physicians are unaware or uncomfortable of the issues. But I was told there's no appetite for making it mandatory, but at least all of these courses should have CMEs attached. Like the CMA just did a wonderful conference, but there were no CMEs offered. So it would be great if we could get more CMEs for this stuff. And I'm just curious, I asked in the chat, I was so embarrassed when I first started talking about climate change and health and discovered all the information that had come out about air pollution and heart disease. And I thought, oh my gosh, I'm a nephrologist and I had no idea how much of cardiac health and strokes had to do with air pollution and living near traffic. And I felt like really stupid and really embarrassed. And yet when I asked in my hospital, gave a talk and said, well, how many of you are aware of this? Nobody knew about it. So there's this kind of siloing of that information, and to call it a social determinant of health, you know, that I only learned in the last 3 years. So I'm curious, is everyone else here familiar with this? And when did that happen? And how do we improve that for not just physicians coming up and training? I think get it, but
most of the new medical schools, I'll just go back. I'm a faculty at and our school started in 2009. And that's when there was a big shift. Most of the medical schools who started since 2009, 2008, 2009, 2010, pretty much incorporate social determinants of health in almost everything. Whether a round, like we have a 3-year curriculum, longitudinal curriculum, most will have it either a one course or some points during the entire 4 years. So it's pretty much in most of the curriculums in all the schools at this point. And so the students coming out are all very much aware.
Right. I think they,
yeah, many are beginning to have more climate programs, and it will be discussed because the students are pushing it. But as a formal curricular change, it hasn't really happened across the board, but it's coming pretty rapidly. But
and what about the practicing physicians who graduated before this?
That's slow. Like we in most of the clinician climate action groups are doing CME courses. I have a whole set that we got funded to do on a Baptist Health System platform, and it's for CMEs with MOCs that you can access in the Baptist Health System in Florida, but it's again more tailored to Florida. And I put a shameless plug, but TED.com, my TED Talk is 12 minutes, and it's designed to get clinicians to see all the aspects of the health impact. And I have one, there's several. Xavier Cortada just did one, another TED Talk. So TED is doing quite a few on health, targeting clinicians.
So those might be good to link to in a conversation. Hey, if you want to learn a little bit, check this out.
Yeah, mine again goes with equity and vulnerable and poverty. So it's 12 minutes, but I go through the same. But there, you'll see those. That's what we've been using here to introduce clinicians.
Yeah, so if you have a link to that would be interesting. A nice resource for us. Thanks, Cheryl.
Yeah.
Well, thanks everybody. This is a great conversation, very educational. So everybody have a great Christmas. We won't have a meeting in December, but we will in January. So we will see you in the new year. Thank you so much.
Thanks.
Yes, to your comment, Melinda, that it's so far beyond. It's all of these environmental things. It's all connected.
Happy holidays, everyone. Bye-bye.
Bye.
Thanks. So grateful for this community.
Yeah.